there is a repetitive cessation of breathing during sleep. So what happens is there is recurrent episodes of apnea leading to repeated hypoxia and hypercapnia, and subsequently there is damage to the retinal nerve fiber layer. So the aim was to study the RNFL thickness using OCT in patients with different severities of OSA, and we hypothesized that RNFL thickness will vary with the severity of OSA as measured by the apnea-hypopnea index. This was a hospital-based prospective cross-sectional study which was conducted at All India Institute of Medical Sciences, Rishikesh. And we included the patients who were diagnosed with OSA by level 1 polysomnography, aged more than 18 years and willing to provide a written informed consent. Those with psychotic or neurological disorders, any substance abuse, or any other chronic diseases or media opacities were excluded from the study. Now, video synchronized polysomnography was conducted as per the American Academy guidelines, and based on the AHI, the patients of OSA were classified into mild, moderate, and severe groups. A comprehensive ophthalmological evaluation was performed in all the patients, and analysis was done by the SPSS version 28 software. So 90 eyes of 90 patients were included, and the average age was close to 50 years. About 1/4 of the study participants were the female gender. As far as the severity goes, 39% were mild OSA, 30% moderate, and 31% were severe OSA. If you look at the average RNFL thickness, it was 86.76 microns. And as you go from the mild to moderate category, it decreased from 89 microns to 81.36 microns in the severe category. Similarly, if you look at the intraocular pressures, they were about 16 in the mild OSA group and increased to 17.43 in the severe OSA group. So we also did a quadrantic analysis, and we found that the average as well as the superior quadrant RNFL thickness was significantly different between the OSA severity subgroups, and this was inversely associated with the apnea-hypopnea index. There was a weak but significant negative correlation between the AHI and the average RNFL thickness. The intraocular pressure differences among the three OSA groups were statistically significant. However, there was no statistically significant difference between the CCT, GC-IPL thickness, and CMT among the three subgroups. So the severe OSA patients had significantly lower average RNFL thickness as compared to the mild OSA patients. This is consistent with previous studies which have been performed elsewhere as well. So superior quadrant RNFL thickness was significantly lower in the severe OSA subgroup, which is in concurrence with studies which have been done by Lin and Lee et al., who also found the superotemporal thinning. And this could be possibly because when OSA causes ischemia and anoxia, it may first affect the superior and the inferior quadrants because of a relatively denser RNFL distribution in these quadrants. Also, the intraocular pressure was significantly higher in patients in the more severe OSA group, which is consistent with findings by Guven as well as Zin et al. And decrease in the ocular perfusion pressure possibly led to results in an elevated IOP and subsequent damage to the RNFL. The limitations of the study were a small sample size, lack of a control group, and we did not do OCT angiography. So in conclusion, the average and superior quadrant RNFL thickness was significantly lower in patients in the more severe OSA group. Patients with severe OSA had higher IOP as compared to the mild OSA group. So moderate to severe OSA patients should be screened for glaucoma. And for known glaucoma patients, screening for OSA may help in monitoring the progression of glaucoma and may prevent blindness in these patients. Thank you for a patient hearing.
Severe OSA. So what was the diagnosis? Was it more common in normal tension glaucoma or POAG?
Ma'am, these were all patients who were normal patients who were diagnosed with OSA. These are not glaucoma patients at all.
So IOP, what was the range? You said higher IOP, so what was the range?
The range of the IOP in the severe OSA group was in the range of 16 to 19. Okay. As compared to the mild group who had lesser this thing. So what they say is that possibly because whenever there is episodes of apnea and hypopnea, there is reperfusion that leads to subsequent inflammation. Then there is also increase in the cerebral pressure, so that the cerebral perfusion pressure decreases.
Those patients had some symptoms. Why did you advise and chose those patients?
Ma'am, those were diagnosed as the obstructive sleep apnea patients.
You chose the patients who were already...
Who were level 1 diagnosed obstructive.
So that means the patients were referred to you from the physician's clinic. So what was the criteria in your clinic?
Basically, we collaborated with the Division of Sleep Medicine in our institute, and we planned the study accordingly. So those patients who were first diagnosed with obstructive sleep apnea by polysomnography, they were then sent to us for further evaluation.
So the patients who are prone for this OSA, sir, they are having many more risk factors like weight, BMI. So did you include those things in your study?
No, we did not include the weight and BMI, but we did include the diabetics and hypertensive patients, and we did a subgroup analysis of those patients. There were 8 patients who were diabetic, 12 were hypertensive, and 8 were again both diabetic and hypertensive. We did a subgroup analysis and found there was no significant difference between the other population and the diabetic and hypertensive group.
Okay, so that was there.
Yeah.
And any confounding factors did you find when you said that the final analysis was done for RNFL?
I don't think so, not really.
Thank you.
Only the converse is the IOP is elevated,
Yeah.
that can cause ocular perfusion reduction.
Yeah.
Or ocular perfusion reduction per se due to other vascular factors, vascular regulatory factors or atherosclerotic factors affecting the fine vessels of ONH can cause disc damage, like glaucomatous disc damage, without elevation in IOP.
Yeah.
But reduction in ocular perfusion pressure per se will not elevate IOP. The converse is true.
Yes.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Now may I call upon Dr. Palumi Ghosh for the next presentation, and she's going to deliver the presentation on relationship of contrast sensitivity using sparks and RNFL thickness in patients with glaucoma. The next, and the number is there, no?
Yes, follow me, go ahead.
Timer, excuse me, the ball. It's there. It's there.
Good morning, everyone. I'll be discussing about the relationship between contrast sensitivity using sparks and RNFL thickness in patients of glaucoma. I have no financial disclosures to make. Now, glaucoma is a leading cause of irreversible blindness worldwide, and as we all know, that gold standard for testing visual function and estimating the disease progression in glaucoma still is the visual field test. Now, there is a proven correlation between the different sectors of the retinal nerve fiber layer damage and the visual field. However, decreased contrast sensitivity in glaucoma patients has also been well documented. Now, to overcome the limitations of visual field testing, especially in old uncooperative patients, contrast sensitivity testing, we hypothesize, can be a very useful tool. Now, why sparks? Now, space enrichment contrast sensitivity test is an online test which can be taken by the patient at home. It measures contrast sensitivity in 1 central and 4 peripheral areas of vision and has no confounding factors of language and intelligence. Now, the purpose of this study was to determine the correlation between contrast sensitivity and retinal nerve fiber layer thickness in different areas of vision in patients of glaucoma, and also to understand the reliability of sparks as an early diagnostic tool in glaucoma, and to understand whether changes in contrast sensitivity can be a potential indicator for the level of glaucoma damage to the retinal nerve fiber layer. It was a prospective observational study. 142 eyes of 91 patients, 18 to 85 years of age, diagnosed as moderate to severe glaucoma at least 1 year prior to joining the study were taken. Any incisional laser eye therapy in the past or any other retinal disorders which can affect the contrast sensitivity were excluded from the. Now, routine anterior and posterior segment examination was done and followed by peripapillary retinal nerve fiber layer thickness measurement using the Cirrus HD OCT. Now, the Sparks test was done using a computer monitor with 1024x768 display resolution in a dark room. The patient was made to sit 50 centimeters in front of the screen and they were made to fixate on the center. Gray bars will flash in one of the 5 areas, and if seen, the fixation was again resumed and the bars flash in a different area. Now, this process was repeated with multiple steps of decreasing contrast until the subject cannot discern the bars any further. Individual scores are given to all the 5 quadrants out of 20 and total out of 100. Now, we correlated the RNFL quadrants and the clock hours to each of the 5 areas of the Sparks test. For example, the left upper Spark zone was correlated with the superior-nasal quadrant in the right eye and the superior-temporal quadrant in the left eye, and the right upper Spark zone for the superior-temporal in the right and the superior-nasal quadrant in the left. Now, overall, we found that the average OCT RNFL thickness and the global Spark score showed a significant correlation in both the eyes. There is a scatter plot showing the same. In individual eyes as well, both the average RNFL thinning and the global Spark score showed a significant correlation. When individual RNFL quadrants and Spark zones were compared, there was correlation found specifically in the inferior quadrant. The right eye inferior RNFL quadrant correlated well with the right upper and the right lower Spark scores, and the left eye it correlated with the left upper and the left lower Spark score. Similarly, less weaker correlation was also found between the superior and the temporal quadrant. However, we could not find any correlation between the nasal and the central zones. Plot showing the same in individual eyes. Now, a close relationship exists between vision-related quality of life and contrast sensitivity in glaucoma. Patients may complain of a poor vision in spite of very good visual acuity, although contrast sensitivity test is not routinely performed in patients of glaucoma. Now, a significant correlation has also been studied between the reduced contrast sensitivity and visual field loss, but the currently available contrast sensitivity testing tools measure only in the center, which is inadequate in a patient of glaucoma where mostly the peripheral vision is affected. The Sparks data has shown and found it to be reliable and specific for glaucoma, and has also seen that it has a significant role in staging severe disease, and was also found to be statistically more sensitive and specific than the Pelly-Robson chart test with a better test-retest repeatability. Now, role of contrast sensitivity individually and Sparks has been and OCT RNFL has been studied in glaucoma well. However, relationship between the both has not been studied widely. In our study, we found that the global RNFL thinning due to glaucomatous damage correlated very well with the decreased contrast sensitivity in the same patient. We also found that the inferior quadrant of the RNFL thinning correlated more strongly with zones of decreased contrast sensitivity in Sparks in both the eyes, probably due to the susceptibility of the inferior region of the RNFL to early glaucomatous damage. And our findings are in line with the previous study, which was done by Amanullah et al. At a different institute. Now, limitations were small sample size and short duration of the study. However, the biggest limitation was lack of follow-up, which resulted in a lack of consistent trend in findings. So in conclusion, now Sparks can be predictive of the RNFL damage in glaucoma, and it can also be a useful tool for the workup and follow-up of moderate to severe glaucoma patients, especially in the post-COVID scenario where most of the patients are reluctant to come to the clinic more often. It is an online test and can be performed at home as well as at the clinic and can be shared with the physician. We also found that the contrast sensitivity testing can be indicate a progressive loss of neural tissue in different areas of the retina. Thank you.
Did you grade the contrast sensitivity like depending upon the severity of glaucoma?
No, ma'am, we could not, because otherwise separately it just gives a score out of 100. So I just wanted to correlate between the thickness and severity separately. I could not in this.
So,
test.
but in OCT, when there is advanced glaucomatous damage, definitely there is a floor effect. So how
Yes,
do you
ma'am.
justify that?
Ma'am, those were the patients that we took who were very well controlled, and we kind of excluded the patients who had some sort of severely advanced glaucomas. We took only moderate to early severe glaucoma. Thank you. Yes, thank you.
Sir, any other questions?
The application of this in day-to-day practice.
Sir, I would probably see in patients who are probably not coming to the clinic very frequently or lack of follow-up is there. So suppose a patient we would like to follow up maybe say 6 monthly or yearly, but however the patient due to debilitated nature or maybe the age of the patient they are not following up. In case if they do this test at home, probably if the results, if we correlate and we find that the results are probably decreasing or showing a gradual decreasing trend, we can call them back to the clinic and maybe intervene with medications. Yes, sir. Yes, sir. But however, the previous study with this showed that it did not have much significance in early glaucomas. Other studies have seen that it doesn't find. So mostly in my study I took only early cataract, and obviously higher severe mode the cataract it can be a confounding factor because of the effect, as well as I think the IOL status as well. In my patients, sir, most of the patients were pseudophakic with monofocal IOLs, and hardly a very few patients were NS1. Very early cataract.
You had any visual acuity criteria?
No, ma'am. No severe, nothing. No visual acuity criteria per se. Just glaucoma patients with moderate to severe glaucoma.
Like because if the
Yes.
visual acuity,
Yes,
even
ma'am.
in 6/6 in advanced
Yes,
glaucoma, the
ma'am.
contrast sensitivity will reduce,
Yes,
but
ma'am.
not in mild to moderate.
Yes, ma'am.
So,
No, we did not.
as such,
take
the
any-
other confounding
Confounding
factors like
factors.
cataract and other
Yes,
things.
ma'am.
So you had excluded everything.
We had excluded.
Any questions, Ajay or others? You also have right to seek clarification from your colleagues. Okay, follow me. Tell me, this is a cross-section study.
Yes, sir.
It's a cross-section study. That's what I understand. Why do you state as a limitation short duration of this study? Only if it's longitudinal we are concerned about.
Yes, sir.
The duration of this. This cross-section.
Yes, sir.
So I don't think.
Actually, my major limitation was the follow-up of the same patients again. Probably, I think the duration should not be. Yes, sir. Yes, sir.
Sample size is.
Yes. Thank you, sir.
Thank you. So now our next speaker is Dr. Pradeep Balam, and after that is Dr. Sahiban Sabharwal around. Sir, Sahiban is not there. So
I saw her. And she was in the
Dr.
other session.
Dr. Sharmila,
We can go to the next presentation and come back.
Dr. Sharmila, no, Dr. Jasleen Dhillon.
Good morning, all. I'd like to thank AIOC for giving me this opportunity.
Sir,
I'm Dr. Pradeep from
Balam.
Shankar Eye Hospital. I'll
Third
be
number.
presenting on the effect of
Third number, sir.
Third.
Yes, sir.
I'll be presenting on the effect of glaucoma medications on lipid layer thickness in patients with newly diagnosed glaucoma. Excuse me, you're moving the mouse actually. Don't move the mouse, okay? Okay. Coming to the introduction, intraocular pressure is the only modifiable risk factor in patient.
Hair time शुरू हो गया ना.
No, this is fine. No. So, coming to the introduction, intraocular pressure is the only modifiable risk factor in patients with glaucoma. Treatment with topical anti-glaucoma medications is essential to prevent the progression of the disease. However, the long-term use of glaucoma medications has led to the ocular surface disease, which is characterized by disruption of the ocular surface integrity, inadequate quantity of tears, and an unstable tear film. LipiView interferometer is a new device that can measure lipid layer thickness quantitatively using interferometry. Materials and methods. Patients attending outpatient department of our hospital who were newly diagnosed with glaucoma and were treated with anti-glaucoma medications forms the source of the study. 3 lipid layer thickness parameters, that is maximum, average and the minimum, measured by LipiView were recorded before starting anti-glaucoma medications and after 12 months of treatment. LipiView has an upper cutoff of 100 interferometric units. Tear film breakup time and Schirmer's values were recorded before starting the treatment. Exclusion criteria being slit lamp evidence of eye surface disorders, current use of contact lenses, patients on topical anti-inflammatory, antibiotic or other medications, ocular surgery or laser treatment, and autoimmune diseases. LipiView is a patented technology that measures the lipid layer thickness with nanometer accuracy, captures the blink dynamics, and images the structure of meibomian glands. This is a real-time visualization of the lipid layer to evaluate the dynamic response of lipids to blinking. Results.
38 eyes of 26 patients were included in the study. The mean age of the subjects was 62 years, ranging from 36 to 72 years. Mean number of medications used was 1.94, and the total daily eye drops used was 3.15. So this is the table showing patients with different types of glaucoma and different class of anti-glaucoma medications prescribed for treating glaucoma. So when we have charted the anti-glaucoma medications used, majority of the patients were on prostaglandin analogs, followed by beta blockers, then carbonic anhydrase inhibitors and alpha agonists. This is the table showing the lipid layer thickness parameters before starting the treatment and after 12 months in patients on single drug. The maximum, average and the minimum LLT parameters before treatment were 80, 64 and 55 respectively. At the end of 12 months, the values have been dropped to 77, 61 and 52. And the p-value was found to be statistically significant, stating that AGMs has an effect on lipid layer thickness. Similarly, in patients who are on double drug, the decrease in LLT parameters were found to be significant, also stating that AGMs has an effect on lipid layer thickness. These are the pictures of right eye and left eye showing lipid layer thickness parameters before the start of anti-glaucoma medications and after 12 months follow-up. The average, maximum and minimum were normal before the treatment, and on 6 months follow-up, all the lipid layer thickness parameters were found to be significantly reduced. Discussion. Longer the duration of topical glaucoma medications and increased number of medications were associated with lower lipid layer thickness. Lee et al. Investigated the effect of topical medications on ocular surface disease and LLT and found that the average lipid layer thickness in glaucoma group was significantly lower. Arita et al. Demonstrated that long-term use of topical glaucoma medications was associated with alteration in meibomian gland morphology and function and has contributed to development of ocular surface disease. Tamley et al. Showed that the prevalence of ocular surface disease varied from 37 to 91% in glaucoma group and was associated with increasing number of topical glaucoma medications. So in our current study, anti-glaucoma medications and their duration were associated with lower lipid layer thickness. So there may be a tendency for the patients to have lower adherence to the prescribed treatment. Therefore, assessment and monitoring of lipid layer thickness changes related to ocular surface disease has a positive effect on treatment adherence and ultimately prevent worsening of glaucoma. Conclusion. Patients on long-term glaucoma medications needs to be assessed for lipid layer thickness to evaluate their ocular surface health. In glaucomatous eyes, duration of treatment and increased number of topical glaucoma medications were associated with lower lipid layer thickness. And ocular surface is strongly related to treatment compliance of topical glaucoma medications. These are my references. Thank you.
When you said that your patients were on these particular number of medications, so all the patients who were included in this study were on same number of medications?
Ma'am, they were on single drug, double drug, different classes of, ma'am, but they were given particular company medicine itself, ma'am.
That is because I was going to ask about the preservative. Was the preservative same in all the groups?
Ma'am, we have preferred BAK drugs itself as a preservative, ma'am, which is having other parborate and all that drugs we have not taken.
You have not included?
Not taken into account.
Okay, so basically it was back only?
Yes, ma'am.
Okay.
So it was maximum with PG analogs? Or?
Ma'am, it was maximum with, because majority of the patients we have treated with PG analogs itself, ma'am. So when we see like majority of the patients who are on PG analogs had developed more drastic changes in lipid layer thickness, ma'am.
I don't think it was a comparative study. So probably we
But
cannot
he had shown one chart wherein the maximum numbers were...
That is regarding the number of patients who were put on, who were prescribed PG analogs.
Yeah,
are also
most
on
of them
PG.
were on PGAs.
Yes, ma'am.
In comparison with back-free?
Sir, that was not done. Preservative free.
I think it's a good idea to compare
Yes,
it with
compare.
back-free
Preservative
now.
free
Yeah.
improvement.
Yes, ma'am.
Yes.
Because now, like we see a lot of patients developing allergy to drugs with preservatives.
Yes, ma'am.
And a lot of them, I don't know, ever since the preservative-free drugs have come into the market, the allergy rates somehow I have seen have
calm down.
increased.
So
very
true. Very less.
Yeah.
Once you opt now, BAK free. I think every company is now coming up.
Yes, sir. BAK free. Yes, ma'am.
So the
You did not mention BAK ratio.
Sir, 15 were men and 11 were.
So that is a confirmed.
Okay, sir. Okay, fine, sir.
It is a confounder. It is a confounder for females if more than 45 years. You have to keep that factor in your mind when you are comparing this.
Okay, ma'am.
Yes. So let's
No, less.
Right,
They have
right.
more
Let's take-
dry eyes.
So dry
Females
eyes,
have hormonal and all this.
Okay, fine.
Yeah.
No,
Hormonal factors.
what was the type of study you recruited patients and then medicated them and followed up?
Yes, sir.
That was what you did?
Yes, sir. First, we have found out newly diagnosed
kind
glaucoma
of a
patients, sir. Then we have
longitudinal
given
study.
medication on 12 months follow-up. Again, we had checked the lipid layer. We have compared the lipid layer.
Newly diagnosed and
Yeah,
checked.
because
newly diagnosed.
I don't know why that newly diagnosed is important.
Sir, because we didn't take into account the patients who were already on medication because it would have already caused damage to the lipid
Damage.
layer.
So-
and
so the
so we
patient-
wanted to start afresh from new
So
patients.
with you, they were the firstly diagnosed
Yes, ma'am. It
patients
was
of
the
glaucoma.
firstly diagnosed patients.
Thank
So you need to
Recommendation on how to tackle this once you get this particular.
Sir, we need that's what, sir. This comes mainly under this evaporative dry eye, sir. So we give drugs such as ribapamide, okay, and diacosol sodium.
So before starting the treatment, their lipid layer was okay.
Ma'am, before it
normal.
was normal, ma'am, and we made sure that those are newly diagnosed, and we made sure that all other exclusion criteria have been removed, and we made sure that their lipid layer was normal before treatment, ma'am. So then after starting treatment, we had
But I
followed.
think the compounding factors have to be because some people are more predisposed
Okay.
to develop dry eyes.
Yes,
The
ma'am.
others are not. Some have more allergies.
Right.
So maybe in the long run, I think you can
Yes, ma'am.
find out.
I'll look into that, ma'am.
Thank you very much.
Thank you.
So with that, we come to the next presentation by Dr. Sahiban, who is going to present the paper on clinical outcome of bent ebb internal needle goniotomy, that is BANG in different stages of open angle glaucoma. Is the timer set? Timer.
Time for 7 minutes.
6. Excuse me, the monitor is being set right now. So can we take the next speaker by that time? So again, coming back to BANG.
Esteemed judges, so I'm going to be presenting my paper on clinical outcomes of bent ab internal needle goniotomy in different stages of primary open angle glaucoma. So very briefly, what is BANG? It is a minimally invasive glaucoma surgery which employs an ab internal approach to de-roof the Schlemm's canal so that a direct communication of the aqueous from the anterior chamber to the Schlemm's canal can be made, and it utilizes just a needle to do that. And it is a low-cost alternative to the more popular Cahook dual blade, whereas it is probably 1/500th in cost. So in the background is that BANG was first presented at American Glaucoma Society in 2019 by Arsham Shabani and Shute. It's their brainchild. As a cost-effective alternative to other TM-based procedures, they presented their paper in 27 eyes of 21 patients and saw that at the end of 6 months, there was a 20% reduction, whereas there was no reduction, significant reduction in the number of medications they could bring about. So very briefly, this is a procedure on BANG. So like any other mixed procedure, you make a temporal incision and use a good cohesive viscoelastic to deepen your anterior chamber and for better visualization. This is how the needle is fashioned. This is the needle needs to be bent little short of 90 degrees and then another slight bend at the tip. So surgical gonio prism is placed and the angle structures are visualized, and then the procedure is carried out. It can either be done from an out to in procedure or an in to out procedure, wherein the needle is hooked and then the horizontal part of the needle, which is bent, strips the trabecular meshwork about 90 to 120 degrees. So the published literature so far has been very limited. Most of these studies have also been published by the innovators themselves, and they have shown that there has been an IOP reduction of 20 to 30% over 6 months. An average AGM reduction of 1 was achieved. 73% of patients could be medication free at the end of 6 months. So the clinical questions that I wanted to answer was, do we achieve a significant reduction in IOP and number of medications in Indian eyes with BANG, and what is the role of BANG in the treatment of mild, moderate and severe glaucoma, and also the fact that is it safe? There is no published studies from India yet. So phaco alone, as we know, can bring about an IOP reduction only very mild to moderately. So this was a retrospective chart review of 30 eyes of 22 patients, 21 out of whom underwent phaco bang. It was done by a single surgeon at a single center, and all glaucoma severity of all grades were taken, mild, moderate and severe, and the patients were followed up over 3 months post-operatively. The type of glaucomas that were included were POAGs and NTGs. Male-female ratio was 9:13. Average age of patients was 59 years. Average mean deviation on the basis of Humphrey visual fields was -8.71 and average CD ratio 0.74. So at the end of 3 months, we saw an IOP reduction of 18.43%. The pre-op IOP was 17, post-operative month 3 IOP was 13.87, and this reduction was statistically significant. The pre-op number of drops were 2.47. Post-operatively, there was, at the end of 3 months, there was a drop reduction of 0.67, which also was statistically significant, and almost half the number of patients had an IOP reduction of less than 25%. Next question is whether it is able to reduce IOP and AGMs throughout all severities of glaucoma. So on that basis, we found that mild and severe cases of glaucoma had a significant reduction in intraocular pressure, except the moderate category, which brought about an IOP reduction of only 9.05%. And as far as the AGM reduction was concerned, mild and moderate patients did well. They had a significant drop in the number of AGMs post-operatively, whereas this severe category did not do well. The AGM reduction was only down by 0.25. We did have complications, however, most of them were managed conservatively. There were transient hyphemas seen, there were steroid responders, there was transient IOP spike, and also cases of peripheral anterior synechiae at the end of 3 months. We do have study limitations from the perspective that it's a retrospective chart review, so no control groups wherein phaco alone was done was taken into consideration. There is no standardized follow-up. We did not stratify it over months. We directly checked the IOP at the end of 3 months for the study. Also, the fact that this was a small sample size and we need longer term follow-up to actually extrapolate these results to our clinical practice. But in conclusion, I would say that there is a significant reduction in IOP and number of medications across all severity of glaucoma. It is a cost-effective and accessible method, accessible to every institution, and also it may delay a more invasive procedure for severe glaucoma. And when a patient is anyway undergoing cataract surgery, involving a bang procedure along with it will probably be a viable first step instead of a more conventional and aggressive surgical intervention for glaucoma. Thank you.
Cataract extraction plus bang, right?
Yes.
It was not bar bang.
It was plus bang.
Huh? Okay.
Yeah.
I just wanted to know. Okay.
So 90 to 120 degrees.
So is there any, have you done gonioscopy after 6 months? This is 3 months follow-up only?
This was 3 months follow-up
okay,
only.
so any scarring or anything?
PAS was there, ma'am. There is PAS. Of course, like now this study concluded about a few months back. So now I have few patients who are following up longer than that. So yes, there has been a lot of also fact that, you know, there is pigment dispersion. I even found a patient that had iris pigment dispersion in the anterior hyaloid phase in an uncomplicated surgery. It probably goes through the zonules.
So we really don't know the long-term
follow-up. Yes.
And the other question is that you said in severe glaucomas the efficacy was less of this procedure. So severe glaucoma in terms of IOP, did you find any difference? Because studies have shown that if the IOP is high, then the reduction of pressure is also better.
Right.
Even
so,
if it's an
this
advanced glaucoma.
Yeah.
So in terms of IOP, like what was the difference? Higher IOP and Because in normal tension glaucoma, the reduction of IOP will be less.
Correct.
Okay,
Correct. So
so-
this is a point that I can't really overemphasize, that the categorization of patients into mild, moderate, and glaucoma was only based on the visual fields. So that's how we categorized it. And yes, you're absolutely right that the number of medications and the IOP drop with patients who have higher IOP is much better.
Much better.
That's why we found that the NTG cohort of patients were less benefited with this procedure compared to the higher POAG spectrums.
Okay, thank you.
Thank you.
And with that, we move ahead with Dr. Jasleen Dhillon with us, and she's going to give talk on pragmatic evaluation of the efficacy of pilocarpine.
So good morning, everyone, and thank you so much for giving me this opportunity. I'd like to say that I have no financial interest in this study. So we studied the role of pilocarpine eye drops in the current scenario by evaluating the impact of the commercial non-availability of these eye drops over a period of 9 months. So we studied the efficacy and role of pilocarpine 2% and its fixed dose combination with timolol 0.5% in IOP control and reducing the need for surgical intervention in select poor prognosis glaucoma eyes on maximal tolerable medication. So we know that pilocarpine has been one of the oldest glaucoma medications, over 100 years old, but is not very commonly used because of its frequent dosing that decreases compliance, side effects, and the advent of PG analogs. So this was a retrospective study. There were 88 patients, a heterogeneous group of open angle, angle closure, and secondary glaucomas with a minimum of 6 months on the medication. There were 2 groups. The first one had pilocarpine 2% in TID dosage, and the second group had the fixed combination of pilocarpine 2% with timolol in a BD dosage. From the electronic record, we identified patients over a period of time from July to December who had been on these medications, and because of the commercial lack of these eye drops, were not able to continue pilocarpine further. So the age, gender, BCVA, CD ratio was noted, the glaucoma was staged, and the IOP was taken on pilocarpine an average of 2 readings, and the IOP of pilocarpine also an average of 2 readings, at least a month after the pilocarpine had been stopped. Those who were on a fixed combination were shifted to timolol before the pressure readings were taken. The time period of the medication and the need for surgical intervention was noted. So the main outcome that was studied was the mean change in IOP of pilocarpine, and the other outcome was the requirement of surgical intervention. And if so, the relationship with the time period of pilocarpine, the mean IOP change, and the grade of glaucoma. The statistical analysis was done as indicated. And so there were 56 male and 32 female patients with a mean age of 63, and 38.64% were on pilocarpine and 61.36% was on the fixed combination. The diagnosis, we had about, most of them were secondary glaucomas, about 45%, and of these, most of them were post-VR surgeries. The glaucoma was advanced in nearly half of them, and the number of anti-glaucoma medication was fairly evenly distributed, with the pilocarpine being the 4th or the 5th medication in many of them. It's interesting to see that a lot of patients were actually allergic to one or more anti-glaucoma medications. And the prime outcome was that the mean IOP of pilocarpine rose from 16.23 plus minus 4.53 to 25.05 plus minus 8.03. And this was a mean of about 8. The percentage increase in IOP from baseline was similar in all the 3 diagnostic groups, whether they were open angle, angle closure, or secondary glaucoma patients. And the need for intervention was there in about a quarter of these patients, and most of them either went for a trabeculectomy or a trab with cataract, and for those where the symptomatic relief was required, it was DLCP. And this need for intervention did not vary with the stage of glaucoma or the time period of the pilocarpine, but was statistically dependent on the increase in IOP. So the median IOP change in the group that needed intervention was 10 millimeters, ranging 8 to 16, versus 7 in the group that did not need intervention. Also, 6 of the eyes that underwent intervention actually were on pilocarpine only for an interim period, and 6 of the 9 trab eyes and 3 of the 7 eyes that underwent combined cataract plus trab had undesirable IOP range. So we all know that there is the concept of target IOP. However, there is a lot of debate on what is exactly optimal for each patient. So there are certain patients where, you know, the benefit and the pros and cons are such that we may have to opt for an additional glaucoma medication. And of course, pilocarpine was not very much favored as a first-line medication or even a third-line medication because of the fact that it has compliance issues, since it needs a very frequent installation, at least 3 to 4 times a day, and also the incidence of brow ache and refractive changes. So in our study, we have seen the effectivity to be about similar to what was studied by West et al., which is about 8.21 millimeters mercury. And the mean decrease in IOP was much more than what has been reported in the very few select studies that are there. And it was also seen that the twice daily administration was equally effective to the single user pilo as 3 times. And we found equivalent rise in IOP in all the 3 categories, which is not so.
Time is up.
Okay. So we did not have any patient that stopped the use of pilocarpine for any tolerability issue. And adding the 3rd or the 4th medication, it was similar to Neil Cunton, who saw that there was about 40 to 60% of patients show a drop in IOP. But does this really continue in long term? That has to be seen. So it was a retrospective study with an inconsistent really follow-up visit. Lack of control group is there and a lack of long-term follow-up. But it is it holds promise, and in adult patients who are on maximal tolerated medication, as it can decrease the need for surgical intervention. These are my references. Thank you.
Thank you. You said that the pilocarpine was given when you had a combined surgery done.
No.
Cataract surgery when the pressures were high, even after.
Those were the interventions. The patients who needed intervention. We basically used it for patients who we were not planning to go for surgery. There were 6 patients who were on interim use because either the other eye had been operated or because they had another surgery, and so this was to be delayed. So that was in about 6 patients.
So this was the single drug which was in the other eye, which you think that the intervention was required. This was a single drug, or along with?
In majority of them, it was the fourth or
drug.
the 5th drug.
Okay. So did you see a additive effect along with PG analogs in any of the patients who were with PG analogs? Usually it is said that both the drugs have an opposite kind of mechanism of action.
Yes, we have not particularly picked out that group separately, but we have seen that the additive effect of pilocarpine when the pilo was off was fairly significant, like 8 millimeters was the median. So anybody who had an increase in IOP of over 10 needed an intervention eventually. So it did bring about, even in absolute eyes, it did bring about that effect that the patient was comfortable and we did not have any of them report any brow ache or any need for removing of the drops. It was also very useful in those who have multi-drug allergies, where possibly this was the third drug.
Okay, thank you. Sir, appreciate it. So thank you very much. And with that we move ahead. Is Dr. Sharmila around? So Dr. Tainpuri. So Sharmila ma'am is not here. Sorry.
Good morning, everyone. I'm going to describe our study titled Altered Levels of Immune Factors in Tears of Eyes with Exfoliation Glaucoma. Glaucoma is often considered as a neurodegenerative disorder as it shares several characteristics with other CNS disorders like Alzheimer's and Parkinson's disease. For instance, all these are more prevalent with increasing age and they are characterized by progressive loss of vulnerable neuron population. In glaucoma, this is the retinal ganglion cell. They often have protein aggregation, and lastly, they typically have immune dysregulation, and this is the aspect that we chose to explore. Hence, our objective was to determine the levels of soluble immune factors in tear fluid of eyes with exfoliation glaucoma, exfoliation syndrome, and controls. This was a cross-sectional study which included these three cohorts. We excluded eyes with prior intraocular pressure lowering therapy, either drops or surgery, or eyes with ocular surface disease, or retinal or neurological disease, or trauma or intraocular inflammation. Following a visual assessment, the first test performed was the Shimmers 1 test, where the tear strip is collected aseptically and stored at minus 80 degrees Celsius till analyzed. All participants underwent a complete eye examination, including the intraocular pressure and gonioscopy, and where indicated OCT and visual fields were done. Based on these tests, the 137 eyes included in the study were divided into these three cohorts. Controls were defined as eyes with intraocular pressure less than 21 mm of mercury with normal optic disc and fields, and we had 48 samples. Pseudoexfoliation syndrome is similar to the controls, in addition to which it had deposits of pseudoexfoliation in the anterior segment, and we had 65 eyes. And lastly, the pseudoexfoliation glaucoma, where we had 24 samples. Coming to the method of tear analysis, the scientists at our GROW lab help us to design and validate an automated fluorescent-based ELISA test which can be performed at the clinic. We have to add 300 microliter of extraction buffer to the tube with the strip, and then 50 microliter of tear elute is added to the cartridge along with a wash buffer. Because of the microfluidic cartridge design, several cytokines can be analyzed from the same sample in triplicate. Currently, levels of 8 cytokines can be analyzed in 90 minutes. We used a Kruskal-Wallis test with Dunn's multiple comparison to evaluate the difference between these two groups, as the data did not follow the normal distribution. Moving on to the results, the age distribution was similar between these three groups. And also, there was no significant difference in the number of males, diabetics, and hypertensive. Among the clinical data, as expected, the intraocular pressure and the CDR ratio was high in pseudoexfoliation glaucoma when compared to the syndrome. Moving on to the immune factor analysis, we found that interleukin-17A levels are high in pseudoexfoliation glaucoma when compared to the syndrome. It is a pro-inflammatory cytokine that plays a crucial role in neurodegenerative diseases. In patients with Alzheimer's disease, raised levels of interleukin-17A were found in the CSF and plasma. And also in several mouse models of glaucoma, following a raised intraocular pressure, there is activation of microglia with the associated upregulation of interleukin-17A. They also found that the interleukin-1B levels were also raised in these mouse models, and I'll move on to that immune factor next. We too found that interleukin-1B levels are higher in pseudoexfoliation glaucoma compared to the syndrome. However, other pro-inflammatory cytokines like interleukin-6 and TNF-alpha did not show any difference among these groups. In large meta-analysis of Alzheimer's disease, raised level of interleukin-1B was found in plasma, and there was no change in levels of interleukin-6 and TNF-alpha. This pattern is similar to our study. The next factor we analyzed is the matrix metalloproteinase 9. We found that the levels were raised in pseudoexfoliation glaucoma when compared to the syndrome. This is a proteolytic enzyme involved in the degradation of extracellular matrix. Raised levels of MMP9 was found in the brain and CSF of patients with Alzheimer's disease, and its upregulation caused blood-brain barrier alteration. A clinical study also showed that raised level of MMP9 in tears of eyes with pseudoexposition glaucoma compared to the syndrome. There was no significant difference in the levels of other immune factors in pseudoexposition glaucoma compared to the other groups. Apart from adding new knowledge, the strength of the study is the inclusion of only treatment-naive eyes, and the limitation of the study is the immune factor level were not analyzed from any other body fluid like aqueous or plasma, as the comparisons would help us to understand the disease pathology better. To conclude, the tear fluid of pseudoexposition glaucoma eyes at the higher levels of interleukin-17A, interleukin-1B, and MMP9. Hence, pseudoexposition glaucoma has a distinct pro-inflammatory immune profile which shows similarities to Alzheimer's disease, and these molecules could serve as target for disease monitoring and therapeutic modulation in future. Thank you.
One question, is this paper published or not yet published?
Not yet published, ma'am.
Achha, you have sent for publication.
We are doing more analysis on that, and we have found that interleukin-1B is consistently high. We had in more samples, and
Okay, not IL-17.
like when we did the analysis, when I sent this for the AIOS thing, this many samples were added, but now we have added more.
Now you are having different results.
Different results, and we found that interleukin-1B is consistently high compared to other levels. That shows more consistently high values.
So the patients, we know that the inflammatory markers become high in patients with glaucoma. So what are the clinical implications? Are there any drugs as yet in pipeline which can...
We have immunomodulators available. So for even interleukin-17A, we have secukinumab and brodalumab. And for interleukin-1B, also drugs are available, cyclosporin. And even for MMP9 also, we have cyclosporin available.
So have you correlated these markers with the symptoms or the signs in the eye?
The samples that we included are mild to moderate pseudoexfoliation glaucoma, but more samples of severe glaucoma should also be included to understand the pathology better.
So have you tried any of these drugs and then you have seen the after effects? No.
No, ma'am. These drugs are for psoriatic arthritis treatment, which they use, the dermatologists use. But we are trying to understand the pathology of the disease, and this is also for the future therapeutic modulation.
Okay. Thank you.
Thank you.
Say the actress number for these factors.
No, sir. We have not taken.
No. Any clinicians? You're a clinician, right?
I'm a fellow.
Yeah, clinician.
Yes, sir.
So you'll be doing a lot of surgeries with exfoliative glaucoma, right?
Yes, sir.
So if you can get the aqueous when you do surgery and correlate it, because aqueous is much closer to the trabecular meshwork pathology.
Yes, sir.
Exfoliative glaucoma than aqueous tears. Doing in tears not a bad idea, but probably going in for a more proximal tissue like aqueous.
Exactly, sir.
If you have trabecular meshwork, it's great.
Yes, sir.
It's very difficult to obtain, right?
And maybe I think while doing cataract surgery, the lens capsule of pseudoexfoliation, because that is also again for pseudoexfoliation. I think that's a very good sample.
We have collected all these samples, but we have not analyzed. In generally, we have collected and kept.
Okay.
Thank you.
Sir, you had a clarity.
No, some are anti-inflammatory if you go through interleukin physiology. There are anti-inflammatory interleukins.
Yes, sir. Interleukin-10 is anti-inflammatory.
Yeah.
And there are so many other interleukins. You are not going into all those.
Yeah.
And if you look at migraine, Parkinson's, where you can get all these imbalance between anti-inflammatory and pro-inflammatory.
Probably they've looked at many interleukins, but these are the ones that are highly differentially expressed.
We have looked at 8 interleukins because we have the biomarker kit. Yeah. So
Based
currently,
on the literature, they will, I don't know the methodology, but based on the literature, probably they'll close in on a few. So that's methodologically easier. It's difficult to assay.
so this is
for all
basically using a biomarker kit that is available in our hospital. So that can analyze only 8 interleukins, 8 cytokines. Thank you.
Okay, thank you very much. Dr. Dodam Tara.
No, it's a treatment naive eyes, all of them.
Sir, आप करके था.
Probably we may not have time. But there are, yeah, sure.
Good morning, everyone. I have no financial disclosure, and I just want to declare that this paper got published in IGA in February edition 2023. So our study is on comparison of effect of audiovisual and verbal instruction on patient performance while performing automated Humphrey visual field testing. So standard automated perimetry is a subjective test that aims to measure a sensitivity threshold in a living organism, and its results are prone to variability. And also it is a psychophysiological test, and cognitive factors also plays in role. So this study attempts to assess whether the audiovisual and verbal instructions affect the patient's understanding of visual field testing in terms of reliability indices and its impact on patient's perception of testing, and also its impact on patient's behavior. The aim and objective is to compare effect of audiovisual and verbal instructions on patient's performance while performing automated visual function. So the study was done in a glaucoma clinic, tertiary eye care center in Tirunelveli. So all patients, study population was all patients reported in the glaucoma clinic for HFA 24:2 visual field testing, and we had a sample size of 120, and it was a prospective study. The patient included were all patients who underwent visual field examinations for 24:2 with no previous experience, and age included was 30 to 75 years. So the patients included in all the three groups were equal in number, like 40 in each groups, and there was no much of difference in the age group in all the three groups. Also not much of gender differences number wise, and even those with glaucoma and non-glaucoma patients in all the three groups are almost equal, and the test duration done in all the three groups were almost equal. So two groups were given verbal instructions only, and the third groups were shown standard video depicting that the details how the perimetry was to be performed. So the difference between the first and the two group, like the verbal group, like strict verbal, and the lenient group verbal, was that the first group was stressed that they should see only, they should press the button only when they are seeing the light, and if they will guess, it will increase the duration of the test. So instructions were translated into local language. And again, like the verbal instruction was given by a single counselor well versed with handling the HFA, and patient with video instructed group were shown the video on the hospital laptop by counselors, and all the patients received like standard instructions. So statistical analysis was done by descriptive statistics of study participants were reported using counts and percentage of categorical variables, and continuous variables were presented using mean and standard deviations. The distribution of the data was assessed for normality using Shapiro-Wilk test and box and whisker plot. Categorical variables were compared between the study groups using chi-square test, and all of the statistical analysis were conducted using software data. So these were the questionnaires, like pre-test questionnaires, which was done just before performing the HFA, and post-test questionnaires, which was done just after the HFA was done. So results from the pre-test questionnaire was that no significant difference in anxiety and stress level in all the three groups were noted, but the patient in the video groups were more relaxed as compared to the other groups. And the patient in the video groups were more motivated to perform the HFA. And again, like patient who understood that this test requires their active participations were higher in the video group again. But there was no statistical difference in confidence level reported in all the three groups. So the post-test questionnaire results were that 40% of the patient in the video group felt that they could perform the test with 100% accuracy as compared to 25% and then 25.5% in the other two groups. Again, like 22.5% of the patient in the video group felt that they guessed more than 50% while performing the visual field test as compared to the other two groups, which were higher, like 57.5% and then 72.5%. And 85% in the video group felt that instruction was helpful in performing the test as compared to 55% and 47.5% in the other two groups. So again, the reliable field was higher for the video instructed group for the right eye as well as for the left eye as compared to the other two groups. So the study saw that visual field reliability was higher, slightly higher for the educational video group. This can be attributed to the better understanding of the procedures through an audio-visual media, and slightly better reliability in the left eye in this study could be due to learning reinforcement experiences gained in the first tested eye. Again, like the video instructed group perform better probably due to introductions of standardized informations by the video, which ensure that the key points were brought to the attention of every patient and serve to reinforce the technician's instructions. In this study, patients with a video instructed group were more relaxed, and also video groups were more motivated for the test after the instructions and felt that the instruction was helpful in performing the test. This could probably because of the projected visual field effect and a better understanding of this novel test. So technician-related bias were eliminated as counseling was done by the counselors, and the technicians were masked to the patient's randomizations. Fatigue factors had no impact on the results outcomes of all the groups. So our study had limitations, like we had a very less number of subjects, and learning effect could have been also because we took the patient who had no any previous experience, and severity of glaucoma was not classified or quantified, and educational status of the patient was not noted. So to conclude, the video instructed group were more motivated and performed the test with less anxiety and stress. And to constrain time limit the extent and quality of information delivered to the patient during the routine visual field testing, the incorporation of video guided counseling session is an effective way of using available clinic time. And it can be helpful for better patient comfort and cooperation by increasing the test reliability.
Thank you.
Sir, any questions?
Okay. So thank you very much. So,
You should have randomly assigned the eye to take care of that. Right eye first, left eye first. You always had right eye first. So take care of that learning. You should have randomly assigned left eye first or right eye.
okay.
For the next 3 papers, we will not have any questions in between. If we have time, we can discuss it at the end.
Yes, sir. Yes, sir. So Dr. Tanya Ray, are you around? Dr. Tanya Ray, yes, please come. Dr. Gazela, okay. And Dr. Bidisha Mahapatra, Dr. Bidisha, okay. And Dr. Sharmila, no, she's not there. She skipped one.
May I start? May I start? So good morning everybody, and thanks to AIOS for giving me this wonderful opportunity. Today my topic is an amniotic membrane umbilical cord graft reflecting new rays towards the glaucoma shunt surgery. I have no financial interest. Introduction: glaucoma drainage devices most frequently used in the treatment of uncontrolled glaucoma. Tube exposure is a serious post-op complication that increases the risk of intraocular infection. Several patch graft used for covering the glaucoma shunt tubes, and the tube exposure rate reduced from 30 to 5% for the first 1 to 5 years. And the incidence of significant thinning and the melting of the graft 15 to 25% within the 2-year post-op, and it is probably due to immune-related process and poor host tissue integration. So the YMUC graft use harvested from the umbilical cord with its compact structure and overlying amniotic membrane, high tensile strength, low immunogenicity, and excellent host tissue integration significantly reduce the graft thinning. So this is the surgical video or the video, the process by which it is processed from the donor tissue, and it is available as an amnio plus thick, sterilized, minimally processed, dehydrated, super thick human umbilical cord derived membrane allograft with thickness 300 micron. And this is the histological picture that showed the devitalized amniotic epithelium, compact stoma, and basement membrane, and it is registered under the Human Organ Transplantation Acts. So the objective of the study to determine the safety and the efficacy of amniotic membrane umbilical cord graft in glaucoma shunt surgery for reducing glaucoma shunt tube exposure. It was an hospital-based prospective non-comparative interventional study, and the informed consent taken and approved by the ethics committee of institution. Inclusion criteria: the patient who had an uncontrolled glaucoma with or without prior failed trabeculectomy and the age 40 to 50 years. And the exclusion criteria: previous GDT surgery, chronic ocular inflammations, and the no PL. So the method: the 50 eyes of the 50 patient with a refractory glaucoma undergoing glaucoma shunt surgery using Ahmed valve and the tube inserted into the anterior chamber and the pars plana, and the tube were covered with an AMUC graft, and the study period 2.5 years in RIO Kolkata. So this is the surgical technique. The first, before implantation of the graft is rinsed and reconstituted with an balance and solution 20 minutes before surgery, and then it is cut into the rectangular shape.
and after that it is placed. After that is placed over the tube portion of the valves and secure underlying sclera with a 90 nylon. Now come to the follow-up. The patient were examined on the first post-op day, then 1 week, 1 month, 3 months, 6 months, and 18 months continued. And the AIOCT were used to assess the patch graft thickness, stability, and the host tissue integrity. So the main outcome measure tube exposure, graft thinning, and the graft-related complication, and secondary outcome measure other complication related to the tubes. So the early graft thinning defined as a more than 20% reduction of the graft thickness at the 3 months. So this is the subject demographic and the preoperative characteristics. So now come to the result. Out of 50 patients, the 6 patients developed early graft thinning, and the 2 patients developed late graft thinning, and the 1 patient developed tube erosion, and none of the patients developed any complication, that is 41. So this is the changes of the thickness of the AIOC graft. The average thickness 385 plus minus 15 at 1 month, and on the 18 month, that is on 274 plus minus 15 micron. So this is a sequential AIOCT. The first picture that shows there is a space between the grafts and the conjunctiva, and within the 12 months, the grafts were well marked with a subconjunctival tissue, maintain thickness with an increased reflectivity, so that the AIOCT shows excellent host tissue integration. And the 12 months, the AMU covered area that is aesthetically more appealing good. And this is an AIOCT pictures of the tube exposure that 1 patient developed. And next is a sequential AIOCT that showing the late graft thinning. So as per published literature, several patch graft used for the covering the tube shunt surgery. So the donor sclera tube exposure 26.08%, and the endophthalmitis 1.7% in 2 years. Donor pericardium tube exposure 7 to 15%, and the progressive thinning occur within 28% within the 2 years. Amniotic membrane tube exposure rate 3.43% in 2 years, and the corneal patch graft tube exposure 2.5%, and complete graft melting occurs, that is 16.6% at 1.7 years. So in my study, the AIOC patch graft, the tube erosion only the 2% in 18-month study, and the endophthalmitis nil. So this is another publication that was published in Ophthalmology Glaucoma 2019. It was a multi-center prospective randomized clinical trial, and the purpose of the study to compare the long-term safety and the efficacy of the amniotic membrane umbilical cord and the pericardium patch graft in reducing glaucoma shunt tube exposure. The tube exposure rate is 2% in the AIOC groups, and the early graft thinning is an 12%, and the late graft thinning is an 5%. In my studies in 18-month follow-up, the early graft thinning 12%, late graft thinning 4%, and the tube erosion 2%. So the conclusion, AIOC grafts are well tolerated, and its high tensile strength, low immunogenicity, and the excellent host tissue integration property exert long-term graft survival. No evidence of the graft rejection, severe inflammations, or the infection associated with patch graft noted. So this treatment option is also beneficial, especially in the limited donor cornea and the eye banking services. These are my references. Thank you.
Thank you. And yes, now we'll call the second speaker. So questions, if needed, we'll take later. So with that, we call Dr. Gazela Bruce. So she's going to talk upon GAT in Indian eyes, a 6 months outcome.
Good morning, everyone, respected judges. So my talk today is about GAT in Indian eyes, 6 months outcomes. And these are the abbreviations which I'll be using. So we all know that trabeculectomy is still the gold standard surgery for glaucoma. But of course, it is not fraught with complications. Like we can see here, there can be overfiltering blebs, shallow anterior chamber, which leads to cataract formation, corneal decompensation, or ultimately there may be bleb failure. And also we see many patients who have been on anti-glaucoma medications for many years, and this is the conjunctiva which they possess. So for that, we have gonioscopy-assisted transluminal trabeculotomy. So it was first, the suture one was first described by Grover et al. And following that, there have been many studies. showing the outcomes of GAT, as we can see here, where the mean post-operative IOP had reduced significantly, and even the success rate, which varies from 58.6% to 100%. So the purpose of our study is to report the outcomes of GAT in Indian eyes. It's a prospective study which was conducted at LV Prasad Eye Institute, and the inclusion criteria as seen from here were patients who are more than 18 years who have either POAG, JOAG, clear cornea, or any of these secondary open angle glaucomas, and those who had uncontrolled IOP of more than 21 mmHg on maximum medical therapy, and who had and or progression with this MMT, and patients who were willing to consent for the procedure. We excluded patients who of course have primary or secondary angle closure disease, or those who have any bleeding disorders, or on whom anticoagulants cannot be stopped, previous glaucoma surgery, or those who are not willing to consent. So we did this evaluation where we checked on all visits, BCVA, IOP, AGM, and the adverse events. And initially we took angle imaging and also visual field. So primary outcomes was IOP and the number of AGM which was being used. Success rate is if the IOP is more than 20% baseline reduction is there, and if 6 to 21 mmHg without further need of surgery, and failure if the IOP is more than 21 with AGM, and if there is requirement of further surgery. As seen here, the pre-op data, we had more of males and more of left eye, and 23 were only GAT and 18 were phaco GAT. Diagnosis was mostly POAG and JOAG, and most of them had severe glaucomatous damage. Of course, showing also on the visual field where it was worse than -16 decibels. Here we can see, of course, GAT 23 and phaco GAT 18. There was a difference in the age in phaco GAT, most probably because these patients required cataract surgery, but otherwise other demographics were similar. And the visual acuity also lower in phaco GAT because of the presence of cataract. Baseline IOP slightly higher in the ones who underwent only GAT, and also pre-op number of AGM. So in the 6 months outcome, we saw that in both the groups, the IOP had reduced significantly, as seen from the p-value here, and also the number of AGM. And of course, visual acuity improved in the phaco GAT patients because they also underwent cataract surgery. The adverse events were mostly, there was a spike of intraocular pressure, especially in the GAT group, which was resolved with glaucoma medications. Also, the next common complication was hyphema, which also resolved in the subsequent visits. There was, of course, one case who had vitreous hemorrhage, who needed vitreous lavage, and one who had blood behind the IOL, in which we had to do an AC wash. And in the GAT group, 6 patients all needed trabeculectomy. So the strengths of this study is that it is a first prospective study to be done in Indian eyes to report the outcomes of GAT. The limitations is that it is a small sample size, of course, with a shorter duration of follow-up. And we can conclude that GAT is a relatively safe procedure in these open angle glaucoma eyes, and it can be combined with cataract surgery in suitable cases. And we did find that there is a significant drop in IOP with a decrease in the number of glaucoma medications. Future prospects, we can conduct more larger sample size studies with longer follow-up. Thank you.
Thank you. With that, we move on to the last speaker for today. That's Dr. Bidisha Mahapatra. So she is going to present a paper on glaucoma screening with community eye care systems in southern Odisha. Is Dr. Sharmila around?
I don't think so. No.
Good morning, one and all. I'll be speaking on piloting integration of targeted glaucoma screening within community eye care systems in southern Odisha. According to WHO, 64 million people globally live with glaucoma, of which 7 million are known to the healthcare systems. Projections suggest that the number of people with glaucoma is to increase to nearly 112 million by 2040. In India, the prevalence of glaucoma varies between 2.3 to 4.7%, with over 90% of patients being unaware of the disease because the disease states asymptomatic and can go undiagnosed until very advanced stages. In a recent review of glaucoma situation in India, it was argued that in resource-limited settings like India, mass community screening or glaucoma case finding is not feasible and suggested that targeted opportunistic screening programs operated at different levels of the system will be more appropriate. So our study, the objective of our study was developing a tool to identify glaucoma suspects at high risk of vision loss at community level, strengthening the existing care pathways and introduce glaucoma interventions at different levels of community services to explore characteristics of patients participating in the screening program, the rate and uptake of glaucoma referrals, and the prevalence and distribution of different types of glaucoma among those who were routinely screened. It was conducted in two phases. The first was the pilot study between October 2019 to March 2021 and the phase 2 April 2022 to March 2023. In Ganjam district of Odisha, the target population was above 40 years of age. Screening was implemented as an add-on to the patient examination and OPD of base hospital at the vision centers and at the outreach camps. Trained technicians use the following tool for screening glaucoma. That's assessment of glaucoma history, intraocular pressure measurement using rebound tonometer, AC depth assessment using torchlight, and optic disc assessment using non-mydriatic fundus camera. This was the referral form which was filled up by the technicians, which included age, family history of glaucoma, blood pressure history, this steroid use, visual acuity, intraocular pressure, pupil reaction, lens status, AC depth, CD ratio, cup asymmetry, and then whether the patient has to be referred or not was checked. In the pilot study, as we focused primarily on patients at high risk of vision loss, so the referral cutoff points was cases with intraocular pressure greater than equal to 30 mm of mercury, cases with vertical cup disc ratio of greater than 0.6, all those in IOP range of 20 to 30 with CDR 0.6 to 0.7, and those with shallow AC with 20 to 30 mm of mercury of pressure. In the phase 2, all the criteria remain same except the cutoff for intraocular pressure was 22 mmHg. The pilot study results showed the approximately 23,000 patients people were screened, of which the percentage of suspects confirmed with glaucoma turned out to be 48%, and screening to diagnosis ratio was 4.1%. In phase 2 results, similarly, 23,000 approximately patients were screened. Percentage of suspects confirmed with glaucoma was 34.7%, and screening to diagnosis was 2.5%. Association between the patient characteristics and compliance with referral showed that elderly patients with advanced vision loss were more compliant with the referral from the community settings. Association of patient characteristics and glaucoma diagnosis: females above 60 years of age, intraocular pressure greater than 30, shallow AC, and CD ratio greater than 0.7 were more associated with glaucoma diagnosis. So we found that 4.1% in the pilot study and 2.5% in phase 2 of those screened and subsequently examined had glaucoma, which is similar to other studies from Nepal, from Central India and Eastern India. These studies were a little bit variant according to the location and the age groups they concentrated on. Though we know that detecting glaucoma at an early stage would be most beneficial, but the uptake of reference and treatment in early stage among the community people from poor and remote background is likely to be low. Therefore, we focused largely on identifying patients at high risk of vision loss from glaucoma and help them benefit from treatment. Each of our primary referral indicators, that is greater than 30 of IOP, CD ratio greater than 0.6, and shallow AC, were all associated with glaucoma diagnosis. 74% of patients in the pilot study who had one of the three risk factors was diagnosed with glaucoma. In phase 2 of our study, we aimed at detecting early glaucoma in community by reducing the threshold for referral, that was greater than 21 mmHg, and use of portable perimetry, and our outcomes were almost similar with slightly lower rate of screening to diagnosis, which was 2.5% against 4.1%, and conversion of suspects to confirmed glaucoma cases 34.7%. Most of the patients we could manage with medical management. Less than 10% went for surgical management, and very few went for visual rehabilitation. So to conclude, integration of simple referral tools and community-based programs and targeted screening for glaucoma among OPD patients can play a critical role in early detection of the disease and prevention of blindness due to glaucoma. Thank you.
I would like to congratulate all the speakers for your new ideas and innovative ideas to research upon. The presentations were good. Thank you very much. And please do keep up the good work to advance the science of glaucoma in our country. I'd like to thank all our co-chairs and really thank all the speakers so that we could complete on time. The next faculty is already waiting anxiously. Thank you. Thank you very much.
Thank you very much. Thank you.